So welcome to chapter 16, where we're really going to focus on one of the more critical areas of pre-hospital care, and that's going to be respiratory emergencies. Now, as EMTs, respiratory complaints are really among the most common reason you're going to be called to the scene. Really, shortness of breath is a symptom that can really be tied to dozens of medical and trauma conditions. For something as small as the common cold to a life-threatening condition like congestive heart failure, a PE. Respiratory emergencies really demand rapid, accurate assessment and intervention, right? So what makes this kind of chapter so important is that even when we don't know the exact cause of shortness of breath, the skills and knowledge you're going to learn here can still allow you to stabilize and even save a patient's life. So the truth is you may not always be able to pinpoint the clinical diagnosis in the field, but what you can do and must do is identify inadequate breathing, provide effective oxygenation or ventilation, and really manage anxiety and hypoxia until the patient reaches definitive care. So throughout this chapter, we're going to explore the underlying anatomy, the physiology of the respiratory system, as well as look at a dozen specific conditions, infectious, chronic, allergic, toxic, traumatic, that can really compromise a patient's ability to breathe. So the information in this chapter really builds on the previous chapters, particularly those on airway management and patient assessment, and it's going to tie them together in real-world scenarios that you're likely going to encounter early and often in your EMS career. So now this slide is going to introduce again the first set of the national EMS education competencies. And specifically here, you are looking at, you're really expected to apply the fundamental knowledge to provide basic emergency care and transportation based on your assessment findings for these acutely ill patients, okay? This is going to include your understanding not only the signs and symptoms of respiratory distress, but also how those findings really shape the interventions that you're going to perform. In essence, your ability to assess and act begins with a firm grasp of pathophysiology, and that's just the understanding of how disease processes interfere with the normal body function. Okay, so your job is not to diagnose conditions like pneumonia or asthma definitively in the field. Instead, you're really there to recognize when the respiratory system is failing and to know what to do about it, right? So that includes administering oxygen, using airway adjuncts, assisting a patient with inhalers or a nebulizer, and just knowing when to escalate care to ALS or a rapid transport. So these competencies aren't just about what you know, they're about what you do in the moment when a patient can't breathe. Now, building on that, here we focus specifically on respiratory emergencies. Okay, you're expected to understand the anatomy, signs, symptoms, and the management strategies for conditions that impact both the upper and lower airways. So now the upper airway includes everything above the vocal cords, you have the nose, the mouth, the pharynxes, and the larynx. While the lower airway is going to include the trachea, the bronchi, the bronchioles, and the alveoli. So when something goes wrong in either system, the result can really impair gas exchange and ultimately lead to hypoxia. So you're going to be trained to recognize when the problem lies in the upper airway and like if it's epiglottitis or croup, as opposed to the lower airway where you're going to see issues like asthma, COPD, and pneumonia. So the ability to differentiate between upper and lower airway involvement helps you select the right interventions, whether that's suctioning, just patient positioning, oxygen administration, or ventilation support. So this competency really ensures that you understand the respiratory system holistically. Okay, so you can manage emergencies with both precision and both confidence. Now, we continue to break down these EMS standards. So we're going to talk again more about the specific respiratory conditions that you're really expected to know wholeheartedly. So these include, epiglottitis, a spontaneous pneumothorax, pulmonary edema, asthma, COPD. Each of these conditions really present differently, but they all have one thing in common, and that's that they're going to compromise the body's ability to ventilate and oxygenate effectively. So So, for instance, epiglottitis, is going to be a bacterial infection we're going to learn about. That causes a potential life-threatening swelling in the upper airway. Spontaneous pneumothorax, that's on the other hand, is more of a sudden collapse of a lung without trauma. And that's often occurring in tall, thin individuals or patients with a kind of an underlying lung disease. Then we have like pulmonary edema. So that usually is a result of heart failure, presents with pink frothy sputum, and kind of wet lung sounds. Then we have asthma and COPD. Both are chronic conditions, but with distinct kind of pathophys. So asthma involves more reversible airway spasms, while COPD is more of a progressive disease that's kind of tied to smoking and irreversible airway damage. So you'll be expected to really know how to assess each condition, recognize its kind of presentation, and apply appropriate interventions in the pre-hospital care setting, even if the exact diagnosis is not confirmed until later at the hospital. So this is where your judgment, supported by strong foundational knowledge, is going to be so important to the job. Now, again, to continue on with these beautiful competencies, this really expands on the range of knowledge you'll need to demonstrate. So in addition to the more common known conditions, like our COPD, you must also be familiar with environmental, industrial exposures, toxic gas inhalation, and infectious diseases. So environmental and industrial exposures, those are often involve inhalation of like chemicals like chlorine, ammonia, pesticides, which can really damage the airway and the lung tissues. Carbon monoxide in particular is called, this is the silent killer because it's odorless, it's colorless, but it's deadly. So understanding how these toxins affect oxygen delivery and recognizing the signs like, headache, dizziness, confusion is critical for early interventions. Then we have infectious diseases like pertussis, cystic fibrosis, and a pulmonary embolism must be a part of a kind of a working knowledge, okay? Pertussis or whooping cough, a bacterial infection that causes, violent coughing spells and is highly contagious, especially in our geriatric and our pediatric populations. Cystic fibrosis is a genetic disorder that leads to like thick, sticky mucus in the lungs that really predisposes a patient to repeated infections and respiratory compromise. Where we have a PE is another, high stakes emergency where a blood clot actually blocks blood flow in the lungs, and it's going to lead to hypoxia or even sudden death. So these diverse conditions all share one critical trait, right? They impair the body's ability to get oxygen in or carbon dioxide out. And your role as an EMT is to intervene as early and effectively as possible. To round out the respiratory conditions outlined in the competencies and the EMS education standards, it highlights two more that are commonly encountered, again, serious, okay? So you have pneumonia and viral respiratory infection. So pneumonia is can be either bacterial or viral, and it's an infection that impacts the lungs alveoli, impairing the exchange of oxygen and carbon dioxide. It's especially dangerous in the young adults, not the young adults, the very young, or the geriatrics, and really individuals with underlying conditions like COPD or heart failure. Patients who often present with a fever, productive cough, chest pain that kind of worsens with breathing, and have signs of respiratory distress. Now, as an EMT, you won't be, again, diagnosing this in the field, right? But you can certainly suspect it based on the history, your assessment findings, the presence of these abnormal lung sounds like crackles or wheezes. And then on the other hand, you have viral respiratory infections. That's going to include stuff like COVID, influenza, and those can be equally concerning due to their rapid spread and wide range of presentations. You can have like mild cold symptoms to severe respiratory compromise. So these illnesses can progress to pneumonia or trigger an asthma or COPD exacerbation. But the final list of competencies really emphasizes that whether the origin is infectious, allergic, traumatic, and whatnot, your goal is always going to be the same, right? It's going to be to assess and manage the airway, provide appropriate oxygen therapy, and then transport to the most appropriate higher definitive care. So now we can transition into the introduction and kind of get this thing started. So patients experiencing difficulty breathing, again, are among the most common, okay? And they're definitely of the most high risk cases that you're going to encounter. Dyspnea, or dyspnea, however you want to say it, it simply means shortness of breath. It's often a symptom rather than an actual diagnosis, okay? So it can stem from, again, a ton of different causes, heart failure, asthma, those toxic exposures, infections. And it's not uncommon for multiple issues to contribute simultaneously. So, for example, a patient with COPD might also have pneumonia, compounding the severity of their symptoms. One of the bigger challenges we face as EMTs is that we are really often unable to determine the exact cause of this shortness of breath in the field. Even in the emergency department, it can take time. It requires diagnostic testing to actually identify that underlying condition. But despite this, we're still able to offer life-saving interventions by recognizing abnormal breathing patterns, assessing airway patency, applying O2, or just supporting ventilations. We can really drastically improve our patient's outcome. Just remember that not being able to breathe, it's going to be terrifying for the patient, okay? So your calm presence, coupled with, correct interventions, can provide immediate relief, even if the long-term diagnosis isn't even known yet. Now, before we can actually understand the diseases and the emergencies that impact the respiratory system, we need to review its structures, okay? So the respiratory system, again, includes more than just the lungs. It encompasses all the anatomical structures that contribute to breathing. That's the diaphragm, the muscles of the chest wall, and the accessory muscles of breathing, like the sternocleidomastoid muscle and the scalene muscles. So these muscles are under both, voluntary and involuntary control, but they're coordinated by nerves from the brain and the spinal cord. The diaphragm, of course, plays a central role. It's the primary muscle of respirations or ventilations and contracts downward to actually create a negative pressure that draws air into the lungs. When these muscular components don't function properly, whether it's due to trauma, fatigue, maybe some type of neurological issue or illness, ventilations actually can be impaired. So even if the lungs themselves are healthy. So this is important to remember when you're assessing a patient. Not all respiratory emergencies originate in the lungs. Sometimes the issue lies in the support structures, and understanding this anatomy allows you to better recognize the source of a patient's difficulty breathing. Now, to build on that, let's take a closer look at the upper airway. So the upper airway includes all the anatomical structures that's located above the level of the vocal cords. Okay, these structures are essential not just for breathing, but also for speech, protection of the lower airway, and kind of conditioning the inhaled air. So air enters the body through the nose and the mouth. It passes through your oral cavity. So it goes through your nasopharynx, your oropharynx, your common pharynx, and it goes down. Okay, and it goes down into the trachea. So, but again, we're not going to talk about the trachea just yet, because that's the lower airway. But your pharynx, again, is more of a muscular tube that kind of directs food and air into the appropriate passages. Okay. The jaw and the tongue, that helps shape airflow, sound production, but also presents a potential obstruction, especially in our unconscious patients, when the tongue actually may fall back and block the airway. So one of the more critical structures here that we're going to talk about is the larynx, okay? And that's often called your voice box, and that's going to sit at the top of the trachea. And that's gonna house your vocal cords and kind of serves as the gateway to the lower respiratory system. Now, at the top of the larynx, you have what's called the epiglottis, okay? That's kind of a leaf-shaped flap of cartilage that kind of acts like a lid. So it closes over the trachea during swallowing to actually prevent food and liquid from entering into the lungs. And if the upper airway becomes obstructed, whether it's by swelling, trauma, maybe a foreign body, the patient can quickly lose the ability to breathe, making early recognition and intervention so important to that patient's overall outcome. Now, here we on 16-1 of your textbook. This kind of provides a good visual breakdown of the upper and lower airway components. You're going to notice that the upper airway, the nose, the mouth, the jaw, pharynx, and larynx, clearly illustrated. They serve to really channel and prepare the air, filtering it, warming it, humidifying it before it actually reaches the more delicate lower airways. So, but now let's focus on the lower airways. Okay, this begins at the level of the trachea. Okay, the trachea itself is a rigid cartilaginous tube that bifurcates into the left and the right bronchi. So these bronchi continue to branch into smaller bronchioles and finally into a cluster of alveoli. Now the alveoli are tiny, kind of balloon-like structures that are surrounded by pulmonary capillaries, and these are the true kind of workhorses of that respiratory system. This is where the oxygen enters the blood and carbon dioxide is actually expelled. Okay, the proximity kind of between the alveolar membranes and the surrounding capillaries it allows for actual efficient gas exchange through the process of diffusion. Now, understanding this anatomy is really essential not only for interpreting disease processes like pneumonia or emphysema, but also for effective patient care in the field, especially when you're deciding whether to auscultate breath sounds or how to interpret these abnormal findings. So now that we kind of outlined the structures, let's shift to the function, specifically the principal role of the lungs, which is going to be your respiration. Okay. Now, respiration is the process by which the body exchanges oxygen and carbon dioxide with the external environment. Okay. So how it works is that air is drawn in through the nose and the mouth, travels down the trachea into the bronchi, then through the bronchioles, and then finally it reaches the alveoli. Okay, and these, which are kind of at the terminal ends of your airway tree. So these alveoli, again, are surrounded by a dense network of pulmonary capillaries. And it's at this interface that the oxygen diffuses in the blood. Well, where carbon dioxide diffuses out to be exhaled, and the exchange is kind of rapid and it's really efficient in healthy lungs. But any a minor disruption, like fluid in the alveoli or inflammation in the bronchioles, can actually significantly impair oxygenation and ventilation. So as an EMT, you should always keep this process in mind when evaluating a patient's respiratory distress. Is the patient having trouble moving air through the bronchioles? Are the alveoli compromised by infection or fluid? Or is there a problem like further up the chain, like an obstruction, or maybe the diaphragm is paralyzed? So your respiratory assessment isn't just about symptoms, it's about understanding the system from intake to exchange. So now, with the structure of the system in mind, let's look at the physiology of respirations. In other words, it's really how the system functions to keep us alive, keep us perfused. So respiration is made up of two core processes. Okay, and now you're going to hear respiration and ventilation kind of hand in hand. Ventilation is technically, the process, the mechanical function of breathing in and out. But and respiration is supposed to be more the diffusion of oxygen molecules and carbon dioxide, whether it's in the alveoli or the capillaries in the tissues. But you're going to hear them synonymously. So try not to get confused by that. And I use them synonymously as well. So when we're looking at two different processes, the mechanical process, you have something called inspiration or inhalation, and expiration or exhalation. Okay, so during inspiration, the diaphragm again is going to contract. Okay, a diaphragm is just a muscle. It separates the abdominal cavity and the thoracic cavity. But when it contracts, it actually goes downwards. Deeper into the abdominal cavity. And then at the same time, the intercostal muscles between the ribs are going to pull the chest upward and outward. Okay, this creates essentially a vacuum that's going to draw air into the lungs by creating a negative pressure inside the chest cavity in the lungs that is lower than atmospheric pressure. Okay, now expiration is the opposite. Okay, so that's the diaphragm in the chest wall actually relax, and the elastic recoil of the lung pushes pushes air and carbon dioxide back out of the body. Okay, so this mechanical process really serves a vital chemical purpose. It brings oxygen into the blood, and then it removes carbon dioxide, which is the major waste product of metabolism. So these gases are exchanged at the level of the alveoli, and this exchange again occurs seamlessly. It must occur that way for cells throughout the body to receive the oxygen that they need to function. So even a small failure in this process, whether it's like a blockage, damage to lung tissues, or muscle fatigue, can cause life-threatening respiratory compromise. So when we assess a patient's breathing, we're really evaluating whether the mechanical, the neurological, or the chemical elements of respirations are working together efficiently. Now that we understand really the mechanical process of respiration, let's kind of take a closer look at what's happening at the microscopic level. On this slide, you have two figures, 16-2, 16-3, which really visually explain gas exchange at the alveolar levels and the tissue levels. So in 16-2, we're going to zoom into a single alveolus and the tiny air sac where the actual gas exchange is occurring. So oxygen from inhaled air diffuses across a thin alveolar membrane into the pulmonary capillaries. That's where it binds to the hemoglobin that's in the red blood cells. At the same time, carbon dioxide, which again is a waste product of cellular metabolism, travels in the opposite direction, moving from the bloodstream into the alveolus to be exhaled. Okay. Then we have on figure 16-3, this expands on this by showing the full body application. So in the tissues, oxygen is delivered from the bloodstream to the cells, okay? And that's while carbon dioxide is picked up to be carried back to the lungs. So this constant cycle of oxygen delivery and carbon dioxide removal is really what keeps our body in balance. So any disruption in this process, whether due to, again, fluid-filled alveoli, constricted airways, maybe a reduced blood flow, can lead to hypoxia, hypercapnia, or both. Okay. So this is why early identification and the correction of respiratory dysfunction is so critical in emergency care. So how does the body know when it should breathe, right? And how much to breathe? So that's where the brainstem actually comes into play. Specifically, the medulla oblongata and the pons constantly monitor the levels of carbon dioxide in the bloodstream. So in our healthy individuals, breathing is primarily driven by an increase in carbon dioxide, right? So it's not by a lack of oxygen. So when carbon dioxide levels rise, the brain will actually signal to the respiratory muscles to increase the rate and the depth of breathing. So this brings more oxygen in and flushes more carbon dioxide out, helping to restore balance. If carbon dioxide levels drop too low, maybe from hyperventilation or trauma, the respiratory drive will actually slow down to retain more carbon dioxide. But there's an important aspect here. In patients with COPD or chronic obstructive pulmonary disease, specifically when we're talking about emphysema is the biggest one, but their bodies actually might become desensitized to elevated carbon dioxide levels, and in those cases, their breathing actually may instead be driven by low oxygen levels. And this is a phenomenon known as the hypoxic drive. It's controversial, but it's to be aware of in the field, because while we never withhold oxygen from a hypoxic patient, especially in acute emergencies, we do need to monitor the respiratory rate and mental status closely in patients with these chronic lung diseases, especially when you're administering high flow oxygen. You may need to assist ventilations if the breathing slows down too much. So remember, breathing is both a mechanical and a neurologic process, and a disruption in either system can quickly compromise the patient's ability to ventilate and to oxygenate. So now let's kind of shift our focus to from normal function to dysfunction, okay? And that's what we call pathophysiology, okay? So here we're going to outline some of the more common ways oxygen exchange can be impaired in the body. Problems with the anatomy of the airway. So swelling, trauma, an obstruction, that can actually prevent air from even reaching the alveoli. Second, you have the disease process, such as like pneumonia, COPD, or pulmonary edema. That can actually directly damage the lung tissues or flood the alveoli with fluid, really preventing gas exchange from taking place. Then we have traumatic conditions like a flail chest, a pneumothorax. That can affect the mechanics of breathing, really making ventilations ineffective when the lungs are intact. Then finally, we can't forget about the pulmonary vasculature. So if blood isn't reaching the lungs, like in a pulmonary embolism, oxygen has nothing to bind to. Okay, so you can think of the respiratory system as like two interdependent parts, right? The airway and the circulation. You need both air moving into the alveoli and blood flowing through the capillaries. Okay, so if either side of the equation fails, gas exchange is going to suffer and the body becomes hypoxic. Okay. So this understanding is what allows you as an EMT to interpret your assessment findings and really tailor your treatment in real time. Now, as an EMT, one of your most important responsibilities is really to recognize the signs and symptoms of inadequate breathing, okay? And really to act aggressively and quickly. So while a patient may look okay, at first glance, things can often deteriorate rapidly, okay? So you'll want to be on the lookout for signs like altered mental status, increased work of breathing, cyanosis, any abnormal breath sounds, or poor chest rise and fall. Additionally, it's also important to be aware of patients with, chronic like carbon dioxide retention. Okay, again, that's typically going to be seen in your late stage COPD patients. These patients, again, have a different respiratory drive. So, as I talked about, that's called the hypoxic drive. So that's where their body uses the low oxygen levels rather than a high carbon dioxide levels like a normal person as the primary stimulus to breathe. So it really is a debated topic in the EMS kind of realm, but the takeaway here is that we should never withhold oxygen from a hypoxic patient if they're in respiratory distress. Okay. Now, if they're calling for something unrelated to their respiratory system, like maybe they're having abdominal pain, maybe they're just like they hurt their ankle. Just because their SpO2 levels are going to read very low, that's going to be technically normal for that patient. Okay, so you don't need to put them on high flow oxygen because that's where you can, in theory, cut their breathing drive completely off. But again, when you are though going to administer oxygen, we want to administer it with caution and like close monitoring. Okay, so if that patient's breathing slows or stops, you need to be ready to assist with ventilations. Okay, again, your role is not to diagnose the underlying disease, but to stabilize the patient's breathing, support oxygenation, and recognize when symptoms suggest like a deeper, more chronic issue. Okay, so that's the critical link between your knowledge and your knowledge of pathophys and your performance in field. Now, as we transition into understanding specific causes of dyspnea or difficulty breathing, this slide really introduces several common conditions that can impair normal respiratory function. Okay, first we're going to look at pulmonary edema. Okay, so this is often result from congestive heart failure. In this condition, fluid builds up in the alveoli, and that physically separates the air from the bloodstream, and it can severely limit gas exchange. Okay, the patient will often present with crackles or rales on auscultation, and even produce frothy pink sputum. Okay, then we have, and we're going to talk more about these later on, but next we have hay fever or an allergic rhinitis. This is caused by inflammation of the upper airway due to allergens like pollen or dust. While not usually an emergency on its own, it can exacerbate more serious conditions like asthma or lead to severe swelling in highly sensitive individuals. Then we have pleural effusion. Again, that's it's another potential cause, which is when fluid accumulates between the lungs and the chest wall, and that compresses the lung and making it harder to expand during inhalation. Then we have an obstructed airway, which can be caused by a foreign body, swelling, or even the tongue in an unresponsive patient. Hyperventilation syndrome is another key condition to note. While it may appear benign at first glance, but especially in our anxious patient, it can stem from a more serious like metabolic imbalance like diabetic ketoacidosis or maybe a toxic ingestion. So while we must consider environmental or industrial exposure, like chlorine ammonia, ammonia inhalation, a drug overdose, especially those involving opioids, which can really suppress the respiratory drive and lead to life-threatening hypoventilation. Each of these conditions, though, affect respirations in different ways. And as an EMT, again, it's your job to recognize which might be in play and respond accordingly. So this slide really explains the mechanisms behind why a patient might experience shortness of breath. Especially for effective gas exchange to take place, air must reach the alveoli and the blood must flow through the capillaries. Okay, so if either side of that equation is kind of impaired, the result is going to be shortness of breath. One possibility is that gas exchange is obstructed. Like, an example, fluid in the alveoli from, pulmonary edema or just thick mucus from pneumonia can block the transfer of oxygen into the blood. Another cause is a damaged alveoli. And again, that's going to be often seen in our emphysemic patients where the walls of the alveoli break down, forming like large spaces that don't exchange gas efficiently. Now, additionally, obstructed air passages can also cause shortness of breath, whether it's from a bronchospasm, like you see in asthma, maybe mucus plugging, or anatomical narrowing from infection or swelling. Another possibility is that the blood flow to the lungs is obstructed, like a pulmonary embolism, where a blood clot travels to the lung and blocks circulation to a part of the lung, even though the alveoli may be functioning properly. And then finally, excessive fluid in the pleural space. And again, we'll call that pleural effusion. So that can compress the lungs and limit the ability to expand, which is going to restrict the ventilation. So in all these scenarios, the end result is impaired oxygenation or impaired removal of carbon dioxide. So these are the underlying reasons behind respiratory distress, and your assessment should aim to determine which of these mechanisms might be involved. So now, here we see a continuation of the causes of dyspnea. It's important to start connecting these pathophysiological processes to just how patients describe what they're feeling. Because shortness of breath isn't just a clinical term. It's really a subjective experience, right? A patient might tell you, I can't catch my breath, or it feels like there's a weight on my chest. Others might describe it just as fatigue or dizziness or a sensation of being smothered. As a provider, your role is really to take these subjective symptoms and correlate them with what you're seeing objectively. So you may observe labored breathing, use of accessory muscle use, cyanosis, abnormal breath sounds, or altered level of consciousness. All of these help you paint kind of a picture of what's really happening internally. At this stage in your training, it's not just about, again, memorizing the conditions. It's about understanding the interplay between a patient's perception, physiology, and your clinical observations. So dyspnea is really a warning sign, and behind it is always a reason. So your job is not to diagnose that reason, but it's to find a reason and to act as quickly as possible, provide appropriate interventions, and then transport the patient for more definitive care. So now to wrap up the causes of shortness of breath, we got to recognize that difficulty breathing isn't always a problem of the lungs, right? So as we talked about, so for many patients, dyspnea is also a sign of cardiac disease when the heart isn't pumping effectively, like in CHF, or congestive heart failure. The fluid backs up into the lungs, really making it difficult to breathe. So these patients may describe a sensation of chest tightness or air hunger, which can feel like they're suffocating despite breathing rapidly. Another factor to concern is pain, especially from injuries to the chest or abdomen. Pain causes patients to take shallow breaths to avoid further discomfort. But it does lead to reduced ventilations and a reduce in gas exchange. So the key point really here is that not all causes of dyspnea originate in the respiratory system. Sometimes the root problem is the heart, the nervous system, musculoskeletal system, or maybe even psychological, like during a panic attack. So as you assess your patient, you need to keep a wide lens and consider whether they're experiencing mechanical issues with their lungs, circulatory issues with their heart, or a nervous system issue that's in fact impacting the respiratory drive. Because, again, with every call, your goal is to identify the likely source of the distress and intervene, okay? And shortness of breath is one of the most universal red flags in the medical field. And as an EMT, you're often going to be the first one to see it and have the first chance to intervene. So now, respiratory infections, again, are among one of the most common causes of dyspnea, and they can affect any part of the airway, upper or lower. So in reality, these infections really vary in severity, ranging from mild congestion to really life-threatening obstruction and respiratory failure. One of the primary problems caused by infections is just the airflow issue. So, and this can happen in several ways. So, in the upper airway, mucus and secretions can actually physically block airflow, and that's going to be kind of seen in conditions like the common cold or diphtheria. Other issues, you have swelling of the soft tissues, like with epiglottitis, which again is the inflammation of the epiglottis, or maybe the larynx, inflammation of the larynx, which can cause croup, and that can dramatically narrow that airway. So these types of obstructions are especially dangerous in our children whose airways are already so small. So meanwhile, like in the lower respiratory tract, you have infections like pneumonia that cause the alveoli to fill with fluid or puts or just like fluid in pus, really impairing the vital exchange of gases. So this airflow or this inadequate oxygenation that's occurring, even if airflow into the lungs appears to be normal. As an EMT, you really won't be diagnosing, again, these conditions definitively in the field, but your assessment, especially auscultating lung sounds, evaluating breathing effort, and just noting fever or mental status will help guide the treatment and transport decisions. Importantly, many of these infections are, again, highly contagious. So always protect yourself and protect others by wearing your PPE, your BSI, your gloves, eye protection, your mask, whenever you suspect a patient with a respiratory infection. So let's start with croup. Now croup is a classic upper airway illness that really it primarily affects young children, usually between the age of like 6 months and 3 years of age. It's caused by a viral infection that really leads to inflammation and swelling of the pharynx, the larynx, and the trachea. Okay. Now, what really sets croup apart from other respiratory infections is just its hallmark symptom of a barking, seal-like cough and stridor, which is a high-pitched sound that's heard during inhalation. Okay. So these signs really indicate that the upper airway is narrowing, making it difficult for air to pass through. So because children's airways are already narrow, even mild swelling can result in significant respiratory distress. Now, fortunately, croup tends to respond really well to humidified oxygen, which can soothe an irritated airway and improve airflow. So, as an EMT, your focus should be on calming the child and avoiding anything that might increase their anxiety. So, and that could also increase the airway narrowing. So avoid inserting anything into the airway or agitating the child unnecessarily. Position the child in comfort, upright posture, provide humidified oxygen if it's available. It's also worthy noting that croup is, again, rarely seen in adults, as their larger airway structures can tolerate swelling much better without causing noticeable symptoms. And for these patients, these typically aren't 911 calls unless, again, it's the patient starts showing signs of hypoxia. Now, a lot of these patients, when we're dealing with children with airway issues, you always want to assess them for dehydration as well, because a lot of times what happens is that the child doesn't want to drink anything because it hurts to swallow, so they won't eat, they won't drink, and then that could lead to dehydration, which is going to exacerbate their overall outcomes. You might also find these patients when you first arrive on scene, like the parent or caregiver might have them in a bathroom with the hot water on to create a steam effect to create humidified oxygen. So that'd be another sign like, hey, there's probably an airway issue of that patient. So just keep that little nugget in mind when you're responding to these calls. Now, epiglottitis, however, okay, this is a potential life-threatening bacterial infection, and again, it causes severe inflammation of the epiglottis. Remember, so the epiglottis is that flap of tissue that covers the trachea during swallowing. So this condition can progress rapidly, especially in the children, and pose a much higher risk of just a complete airway obstruction. Okay, now, thankfully for widespread vaccinations, which is the HIB, which is the I'm going to butcher this, the Haemophilus influenza type B. Okay, but it's called the HIB. Epiglottitis is actually now very uncommon in children, but again, it can still occur in both pediatric and adult populations. Children with epiglottitis appear, very sick. They might be drooling. That's going to be a very telltale sign, and typically sit in a tripod position, which again is leaning forward with hands on their knees or a surface to actually hold up their open airway. They might also have like a fever, like with any type of itis or inflammation, that's an infection, so they might have a fever, and they might have stridor, which is going to be a late sign, but it further indicates that the airway is dangerously narrowed, okay? Now, as an EMT, your goal, again, is to minimize distress, avoid doing anything that might stimulate the child to cry, such as like forcing an exam or inserting an airway adjunct. Now, these actions could lead to a sudden airway collapse. So you really need to provide high flow oxygen and allow the child to remain in a position of comfort, okay? Transport should be rapid and gentle with advanced airway equipment if it's available. Adults with epiglottitis may present similarly with sore throat, difficulty swallowing, stridor, and also should be transported without delay. So recognizing this condition and acting with caution can be the difference between life and death for this patient. Now, RSV. So RSV is becoming, again, the past few years have been becoming very a big concern, especially in the parent kind of community for our pediatrics. So this is respiratory sinusoidal virus. It's really one of the more common causes of a lower respiratory tract infection in infants and young children, especially under the age of 2. Okay, highly contagious virus, spreads rapidly through droplets like coughing, sneezing, and surface contact, making it really concerning in like daycares and households with a lot of children. RSV actually causes inflammation of the bronchioles and lungs, leading to symptoms like coughing, wheezing, fever, dehydration. So these children often present with rapid breathing, nasal flaring, and signs of respiratory fatigue. Really, with any of these pediatric or infant patients, if they're having any type of respiratory stress, you're looking at the nares to flare open. And you're looking for retractions in kind of the ribs and the neck area. So and that's where the skin just kind of sucks in around those ribs, okay? Those are telltale signs that, hey, this is like a true medical emergency. You need to get some definitive care rapidly. Now, since RSV increases also mucus production and narrows the airways, the child may appear to be working very hard to breathe, okay? It's, again, very important for infants. These infants might refuse to eat, might refuse to drink. So, again, you need to be alert of those signs for dehydration, which can worsen the condition. Now, again, how do you look for dehydration in our infants? Well, typically you're going to look at the fontanelles, so the openings on the skull, which we're going to talk about a little bit later on. But yeah, so if those are kind of really sunken in, that's a sign of dehydration. You could also look at skin tuger, see tenting on the skin when you like kind of pinch it. Does it kind of is the skin elastic, or does it kind of stay kind of tented up? And we'll talk about that a little bit later on in the semester. Now, treatment in the pre-hospital setting, it's going to be like with most things, primarily supportive. Administer humidified oxygen if it's available, and just allow the child to sit in a position that kind of eases their breathing. Suctioning may be necessary to clear like nasal secretions if it's compromising airflow, especially in the infants. But you really want to reassess frequently. Children with RSV can decompensate fairly quickly. Also remember to protect yourself and other patients. So use gloves, masks, clean your equipment, and disinfect after every single call. Now, bronchiolitis, okay, so this is another viral respiratory illness. Typically impacts, again, infants and toddlers, particularly during the winter and early kind of spring months. So the condition is most often caused by RSV, which we just discussed, but in bronchiolitis, the bronchioles, which are the small branches of the lower airway, those become inflamed, they swell, and they fill with mucus. So because infants and toddlers have such narrow airways to begin with, even just slight swelling and mucus accumulation can cause significant airflow restriction. And then clinically, now these young patients may present with rapid breathing, wheezing, nasal congestion, fever, sometimes dehydration, just due to poor feedings. In severe cases, the child actually may appear lethargic, so they're very tired, or cyanotic. Now, as an EMT, again, your treatment is just going to be supportive, provide oxygen therapy as needed, and just continuously monitor for signs of deterioration. Like grunting, those nasal flarings, retractions, or just decreased responsiveness. Now, suctioning of the nasal passages may be necessary to relieve the obstruction, ease breathing, especially in infants who are basically nose breathers. Keep the child in a position of comfort, which is going to typically be upright, and then just prepare for rapid transport if the respiratory distress worsens. Importantly, in bronchiolitis, it can be a precursor to future asthma development. So again, careful documentation and communication with the receiving facility is necessary. Now, pneumonia is really one of the more serious and common respiratory illnesses across pretty much all age groups. So pneumonia is an infection of the lungs that really causes the alveoli to fill up with fluid, with pus, or just cellular debris, and it disrupts the normal exchange of oxygen and carbon dioxide. Now, pneumonia can be bacterial, which really tends to have a rapid onset with a high fever, productive cough, or viral, which usually presents more kind of gradually and is often less severe. But regardless of the cause, pneumonia is especially dangerous for people who are chronically ill, immunocompromised, or the elderly, as they really might not be able to mount a strong immune response, and it can deteriorate quickly. So clinical signs include fever, chills, cough, chest pain that kind of worsens with inspiration, abnormal lung sounds like crackles or wheezing. Some patients actually might have green, red, or kind of rust-colored sputum, and others, like particularly children and elderly, may show signs of abdominal pain, vomiting, altered level of consciousness. So as an EMT, your priority really is to provide airway support, supplemental oxygen, even if the patient's oxygen saturation is borderline. You want to assess breath sounds, observe for signs of fatigue or labored breathing, and really be ready to assist with ventilations as it's indicated. But really, early recognition and prompt transport can significantly improve outcomes, especially in these high-risk populations. Then we have pertussis. This is also known as whooping cough, a highly contagious bacterial infection that usually impacts the young children, especially those 6 years and younger. It's spread through droplets in the air and begins with symptoms that really resemble a common cold, sneezing, coughing, a low-grade fever. But whooping cough or pertussis soon can progress into severe coughing fits, followed by that high-pitched whoop sound during inhalation. These fits, these coughing fits, can be intense, very long, and it could lead to vomiting, exhaustion, and in infants it could lead to cyanosis or apnea. So one of the biggest dangers of pertussis is that it can impair the ability to breathe effectively during and after a coughing spell. Now, infants, especially those 6 months and old, under 6 months old, are pretty much at the greatest risk for complications, and those complications can include pneumonia or just respiratory failure. Now, treatment in the field includes, monitoring for airway obstruction, suctioning the thick secretions as indicated, and provide oxygen. Now, again, like with all these, you need to watch for dehydrations because, again, as these patients might not want or be able to eat or drink. In adults and pediatrics, pertussis may present as a prolonged cough lasting weeks, but without that classic whooping sound. But it can still spread like an infection to those vulnerable populations. So you want to take airborne precautions, wear proper PPE, especially when caring for those infants and unvaccinated children. Expedited transport is really essential for these patients just to prevent deterioration. Now, influenza. So let's talk about influenza type A. So this is the one that's commonly referred to as just the flu. Now, it's a viral respiratory illness, and it really impacts people across the entire world. It kind of gained renewed attention back in 2009 when we had the H1N1 pandemic, which really emphasized how quickly and severely this virus can spread and impact public health. Influenza is also transmitted via droplets from coughing, sneezing, or just touching contaminated surfaces. And it really tends to spread rapidly in close quarters, like nursing homes, schools, and just your house. Typical symptoms include fever, chills, a cough, sore throat, muscle aches, headache, fatigue. Now, while many people do recover with just simple rest and hydration, others, especially the very young and the elderly or the chronic health issue individuals, those can develop serious complications like pneumonia or dehydration, and in some rare cases, sepsis. But from an EMS perspective, patients with influenza, again, they're probably not going to call 911 until their symptoms really escalate into difficulty breathing, confusion, or maybe even chest pain. So if you suspect the flu, your care again should focus on more protecting the airway, providing oxygen, and just supporting vital signs as it's indicated. You want to make sure you're wearing your proper PPE. Consider influenza's potential impact just on your own health and your family's health, especially when we're talking about during peak flu season. Now, these are the calls where really infection control protocols matter the most, not just for your safety, but again but to help stop the community, the spread across your community. Now, COVID-19, this is caused by the SARS-CoV-2 virus. Now, it has it has had an unprecedented impact on global health and emergency response systems. Though it belongs to the coronavirus family, which includes viruses responsible for the common cold, COVID-19 can actually lead to severe respiratory illness. And again, in those specific demographics like the elderly, people living in kind of a group settings, and individuals with weak immune systems. It is also spread through droplets from coughing, sneezing, or just talking, and it can remain airborne or on surfaces for extended periods of time, which just increases the risk of transmission. Now, common symptoms include fever, cough, shortness of breath, maybe chest pain, a loss of smell or taste. Now, what makes COVID-19 especially dangerous was how rapidly the respiratory deterioration can occur. Okay, a patient who appears stable may quickly develop hypoxia, even before they feel short of breath. So, and this is a phenomenon sometimes referred to as a silent hypoxia. Now, as an EMT, your priority is really to protect yourself with full PPE, and again, that's going to include gloves, eye protection, and 95 mask. And then again, you're going to try to minimize those aerosol generating procedures unless absolutely necessary. Now, when treating suspected COVID-19 patients, you need to provide oxygen support, monitor O2 sats, and avoid crowding the airway with unnecessary interventions. You should really transport as quickly as possible, and again, definitely alert the receiving facility so they can prepare for isolation precautions. Because again, COVID-19 has really redefined how we approach respiratory calls, and it's the vigilance in your assessment and protection that's going to be what's going to be essential for these calls. Tuberculosis, TB. So now this is a bacterial infection that's most commonly impacting the lungs, though it can spread to other parts of the body like the kidneys, the spine, or the brain. TB spreads through the air when an infected person coughs, and some strains actually are resistant to antibiotics, and that makes it particularly difficult to treat. TB can actually remain inactive or just or latent for years without causing symptoms or being contagious. But when a person's immune system actually weakens, that's when the bacteria becomes active and highly infectious. Symptoms of active TB include, persistent cough, fever, night sweats, fatigue, unexpected or unexplained weight loss. In more advanced stages, patients will have a productive cough with bloody sputum and a shortness of breath, of course. Now, TB is more common in populations that live in close quarters, like prisons, nursing homes, shelters, and in patients with compromised immunity, such as those with HIV. Now, for EMTs, the most important aspect of TB, again, is going to be, or TB interventions and care, is going to be your own personal protection. Always wear your gloves, eye protection, and again, a fit tested N95 mask. You want to place a surgical mask or an oxygen mask on the patient to really minimize the spread of droplets, and then transport should be done carefully, but very promptly, and early notification of the receiving facility is also important, just so they can prepare for isolation. But tuberculosis is slow to present, but once it's active, it can be devastating. So prevention through proper PPE is going to be your best defense. Now, let's kind of turn to acute pulmonary edema. So a true medical emergency where the fluid actually starts to accumulate in the alveoli. And this interferes with oxygen and carbon dioxide exchange. So this is most often caused by congestive heart failure, especially the left side of the heart, where it's not able to pump blood efficiently. Now, as the heart's pumping ability weakens, blood backs up into the lungs and fluid leaks into the alveolar spaces. So when this happens, patients feel like they're kind of drowning, and in many ways they are. Symptoms of this one include severe shortness of breath, cyanosis, clammy skin, and in more of the severe cases, you're going to have this pink frothy sputum that comes from the nose or the mouth. Now, most patients will have a known history of chronic heart failure, and many have contributing factors like hypertension, AFib, or maybe a recent MI. Pulmonary edema can also occur from inhalation injuries, high altitude exposure, or just trauma to the actual lungs. These patients are often extremely anxious and may appear in obvious distress, breathing rapidly and shallow. So it's important to recognize pulmonary edema early because without prompt treatment, the patient can go into respiratory arrest. So on your assessment, you may hear crackles or rales in the lungs, maybe diminished breath sounds in the alveoli. You may hear diminished lung sounds because the alveoli are kind of just flooded with fluid. So these are really among the more sick patients you're going to encounter, and they just like with a lot of these, they demand like swift action and specific care so they don't deteriorate. Now this slide shows a figure 16-6. It shows what happens during pulmonary edema. Now, specifically at the alveolar level. So in a healthy lung, the alveolar wall is in close contact with the capillaries, and that's what allows for the gas exchange to take place. But when in pulmonary edema, fluid fills those alveoli and it separates them from the capillaries. And that creates a physical barrier that prevents oxygen from entering the bloodstream. So this image kind of reinforces why these patients are hypoxic and often despite high respiratory rates. So they may be breathing rapidly but are unable to move oxygen into their system or get carbon dioxide out. Management in the field, it really includes just administering 100% oxygen, positioning the patient upright to kind of ease the breathing, and provide suction if they have fluid in their mouth or their nose. In many systems, EMTs may be trained to use what's called a CPAP device, which is a continuous positive airway pressure device. And that's going to help force fluid back into the capillaries and kind of reopen those collapsed alveoli. CPAP is really effective if the patient is alert and cooperative, but if the patient deteriorates, becomes lethargic, or unable to maintain their airway, you'll need to assist ventilations with a bag valve mask and prepare for rapid transport. It's also important to monitor blood pressure closely, as a patient can be hypertensive to hypotensive as that condition progresses. So time is of the essence with pulmonary edema, and every minute's going to count. So ensuring you implement the correct treatment and the right interventions at a timely pace is going to really make the difference for that patient. So now let's kind of look at the COPD. So this is chronic obstructive pulmonary disease, and it's actually a category of chronic lung disease. It's essentially a long-term deterioration of the airways and alveoli that is kind of progressive and irreversible. So the most common forms of COPD are emphysema, chronic bronchitis. Those are the most common. Some people throw asthma in there as well. But most of your patients are going to have a mix of the emphysema and chronic bronchitis. In the US, the #1 cause of COPD is going to be cigarette smoking. It could also be due to inhaling other toxic substances over a long period of time, pretty much years, or just repeated severe infection. But smoking really is by far the biggest factor. You want to think of COPD as kind of the long-term consequence of just lung irritation, right? Smoke irritates the airways day in and day out, causing them to become inflamed, causing them to be swollen and filled with mucus, okay? At the same time, smoke and just other irritants really damage the alveoli, and they lose their elasticity and break down. Okay. Over years, the chronic obstruction and damage leads to the lungs that just don't function that well. Air gets trapped, the gas exchange is poor, and the patient just has to work hard just to breathe all the time. Now, COPD is actually one of the leading causes of death in the country, even though it develops very slowly. So let's kind of break down the major components, okay? So chronic bronchitis and emphysema. Now, chronic bronchitis is basically an ongoing productive cough with just excess mucus production in the airways. The bronchi and the bronchioles are constantly irritated. So the body's response is to produce mucus and swell the airway linings, which ironically makes airflow just worse. So patients with chronic bronchitis, they're going to wheeze, have rhonchi, just because the mucus is in their airways, and a chronic cough is also going to develop, and they tend to actually be bloated or overweight from just an overall lack of activity. They have chronically low oxygen levels, which causes cyanosis and also lead to edema in the legs or belly if the heart is impacted at all. Chronic hypoxia can actually even cause clubbing of the fingers over time. Emphysema, on the other hand, is really all about the alveoli. In your emphysema, the alveolar wall is destroyed. It loses elasticity, and that really forms larger, fragile air sacs instead of the elastic ones that we have. You kind of think about this as like a sponge turning into a plastic bag. You lose surface area and the ability to recoil, so air gets trapped in the lungs because the alveoli just don't spring back to kind of expel it. An emphysemic patient actually often develops what looks like a barrel-shaped chest just from years of overinflation of the lungs. They're typically thin with kind of muscle wasting, and that's just breathing just burns a lot of calories when it's hard work, so they just kind of look very thin and decrepit. They may breathe with pursed lips to create their own kind of back pressure and keep those airways open. They are sometimes called like pink puffers, pink because they often maintain near normal oxygen until late by increasing their work of breathing, and puffers do that pursed lips breathing. Now, most patients with COPD really exhibit elements of both emphysema and chronic bronchitis. Although the severity and imbalance between the systems kind of vary. In emphysema, the key features is the loss of the elasticity in the alveolar walls, and that results in poor air exchange and long expiration phases. Okay. Now, these patients often appear thin. They breathe through pursed lips, and they may sit in a tripod position to really help engage those accessory muscle use during respirations. Now, in contrast, your chronic bronchitis presents with a productive cough, cyanosis, and frequent respiratory infections, and that's due to the excessive amount of mucus and just the inability to clear that mucus from the bronchial tree. Now, over time, both of the COPD result in chronic hypoxia, and that places a big strain on the actual heart. Okay, now particularly the right side of the heart. It can actually eventually lead to what's called cor pulmonale, or right-sided heart failure. Okay, now what's important for us as EMTs is to understand that these patients really have limited respiratory reserve. So even a mild respiratory infection or environmental trigger can push them into acute decompensation. So they may complain of increased shortness of breath, wheezing, fatigue, or just simply say something like, "I just don't feel right." So early recognition and intervention, providing oxygen, assisted with prescribed inhalers, and preparing for possible positive pressure ventilation support, that can help stabilize the patient before their condition becomes more severe. Now, here we have in figure 16-7, this illustrates the long-term damage that's seen in COPD, because over time, repeated inflammation and exposure to irritants cause scarring, obstruction, and just dilation of the alveolar sacs. Okay, in emphysema, the alveoli merge into larger dysfunctional air spaces, and that significantly reduces the surface area for gas exchange. Okay, now this results in decreased oxygen uptake and increased carbon dioxide retention. Clinically speaking, it's important to remember that not all wheezing equals asthma. In fact, wheezing is a very common finding in COPD. Now, however, it's not always present, and in some cases, you may find diminished or nearly absent lung sounds, and that could be more concerning. Another key takeaway from the slide is the difference between a wet and dry lung sound. Okay, patients with pulmonary edema, often from heart failure, tend to have wet, crackling sounds, where patients from COPD typically have dry wheezing. Now, however, real patients don't always follow your textbook presentation, and some individuals have both COPD and heart failure, which can make the picture definitely more complex. So the golden rule here is really treat the patient, not just the lung sounds. Focus on their symptoms, their oxygenation status, and the level of consciousness to kind of guide your interventions. Now, as we conclude with the COPD, it's really it's worth reinforcing some of the clinical pearls of wisdom, so to speak. Patients with COPD often have long-standing symptoms, including dyspnea with activity, chronic coughing, fatigue. But when they call 911, it's usually because something has changed, right? So maybe their oxygen levels dropped, their sputum has changed color or volume, or they just feel more exhausted than usual. So these are the signs of a potential acute exacerbation. Okay, so when you arrive, you may find them sitting up, using accessory muscles, tripoding, or just gasping for breath. They may have what we call a barrel chest, pursed lips breathing, or and have a sign or history of multiple hospital admissions due to respiratory issues. Now, during your assessment, you want to listen for those wheezing, rhonchi, diminished breath sounds, and look for those signs of cyanosis or altered mental status. You want to administer oxygen, typically starting with a nasal cannula and increasing as needed, and be ready to assist with prescribed inhaler or a nebulizer. You want to monitor their SpO2 readings and their mental status. Remember, if they begin to kind of tire, become confused, this may indicate respiratory failure. In these cases, you'll provide positive pressure ventilations and then transport rapidly to a facility that's really capable of providing advanced respiratory support. So really, early recognition and supportive care are the key to preventing any further deterioration for these patients. So asthma, hay fever, and anaphylaxis, they're all examples of a hypersensitivity reaction, okay? And that just means that the body's immune system is overreacting, sometimes mildly, sometimes in ways that are actually life-threatening. So in these cases, a patient's respiratory distress is not due to infection or trauma, but rather it's an exaggerated immune response to a substance, okay? And that substance is known as an allergen. Now, this substance can be something inhaled, like pollen or dust. It can be ingested, like certain foods or medications, or it can be injected, like an insect sting and where the venom gets in there, or like penicillin, for example. Now, interestingly, in some patients, particularly those with asthma, there may be no identifiable trigger at all. This really makes the situation even more dangerous because patients may not be able to anticipate or prevent an attack from occurring. Now, in EMS, we need to be especially alert when a patient says they have a history of any of these conditions because the severity of the reaction can just escalate rapidly. Now, it's really important to understand that while hay fever might present like, a minor inconvenience, asthma and anaphylaxis can become life-threatening within several minutes. Now, recognizing the difference between them and being able to intervene aggressively, that can be the deciding factor in a successful outcome. So let's begin with asthma. So this is a condition that involves an acute spasm of the bronchioles, which are the smallest branches of the lower airway. Now, during an asthma attack, the muscles around the bronchioles tighten, and the lining becomes inflamed, and the airway is going to fill up with just thick mucus. And that makes it extremely difficult for air to flow in and out. Now, as you see here in figure 16-8, this shows a cross-section of what a normal bronchiole is compared to one that spasms during an asthma attack. Now, as you see, the airways narrow considerably and become obstructed by what's called a mucus plug, and that really prevents effective airflow, especially during exhalation. Now, this is why it's really a hallmark sign of asthma is wheezing, and that's a high-pitched sound heard as air is pushed through that narrowed passage. Now, in some cases, if the airway is like completely obstructed, you may not hear any breath sounds at all. And that's a very concerning sign, and that may indicate just impending respiratory failure. It's also important to know that asthma is a reversible airway disease. So with appropriate medications, the bronchioles can relax, inflammation can kind of reduce, and breathing can improve relatively quickly. Now, and that's really why it's really important to have early recognition and support, and that's going to be often through assisting with a prescribed inhaler or nebulizer, and that's going to be one of the more definitive treatments you can do in the field as an EMT. Now, asthma really impacts people of all ages, but the highest prevalence is really found between children of 5 and 17 years old. Okay, now these patients are often familiar with their condition and may even tell you, I'm having an asthma attack. But asthma can be triggered by a wide variety of things: allergens, cold air, exercise, respiratory infections, even emotional stress. So in all these cases, the mechanism is the same, and that's going to be a bronchospasm, inflammation, and mucus production that just restricts the airflow. Now, as an EMT, our job is to assess how severe the attack is and how the patient is responding. Now, mild attacks may present with wheezing and shortness of breath, while the more severe cases can cause accessory muscle use, cyanosis, and fatigue just from that effort of breathing. One important clue to the severity is the patient's ability to speak. So if they can only say a few words at a time, they're likely in significant distress. So most asthma patients do carry what's called a rescue inhaler or a metered-dose inhaler, which is going to contain a bronchodilator like albuterol. Now, depending on your local protocol, you may assist them in using this medication, which can provide a kind of fast relief. But it's really important to remember, if their condition doesn't improve or actually worsens despite the treatment, they are at risk of progressing to what's called status asthmaticus, which is a prolonged, unrelieved asthma attack that can lead to respiratory failure. So early intervention, again, rapid transport are going to be essential for these patients. So let's kind of shift our attention away from hay fever and asthma and kind of talk about anaphylaxis. Okay, now hay fever or allergic rhinitis is a common condition triggered by airborne allergens like pollen, dust mites, or pet dander. It just causes cold-like symptoms, and that's gonna be your runny nose, your sneezing, congestion, some sinus pressure. Now, while it's not life-threatening by itself, people who suffer from it often have increased sensitivity to other allergens and may also have asthma or history of anaphylaxis. Now, anaphylaxis is going to be the big one. This is going to be a more severe, what we call systemic allergic reaction, and that can cause total airway obstruction and even shock. It really involves widespread vasodilation, airway swelling, and bronchoconstriction. So a dangerous combination that can rapidly lead to death if it's not treated aggressively. Patients experiencing anaphylaxis may present with urticaria, which is the hives all over the body, angioedema, which is a bunch of facial swelling, stridor, wheezing, hypotension, and altered level of consciousness. Now, these patients require immediate treatment, okay, and that's going to include epinephrine, oxygen, antihistamines. Many of your patients who have a severe allergic reaction or allergen, they may carry what's called an EpiPen, and you may be, again, depending on your protocol, be able to assist with the administration of this medication. It is an auto-injector pen. Okay. Now, the key takeaway here is that is the urgency. Okay. Anaphylaxis is a true medical emergency, and even if the patient initially seems stable, symptoms can escalate rapidly. So you always want to err on the side of caution and early intervention and rapid transport for those presenting with the textbook signs of an anaphylaxis. A pneumothorax. So a pneumothorax occurs when air actually collects in the pleural space, and that's the area between the lung and the chest wall. Now, normally the space is under what we call negative pressure, and that's going to keep the lungs inflated. But when air actually enters the space, the pressure is going to equalize, and the lung is going to collapse, whether it's partially collapsed or completely. Now, trauma is going to be the most common cause of pneumothorax, but when we're talking about spontaneous pneumothorax, this occurs without injury and is typically due to a rupture of a weakened portion of the lung. This condition is more aligned and common in patients with underlying lung disease like COPD or emphysema, but it can be also affect otherwise healthy individuals, especially our tall patients and thin young men, and those who engage in activities involving like pressure changes like diving or high altitude hiking or climbing. Now, what makes spontaneous pneumothorax so dangerous is that it occurs suddenly without warning. So the patient might be sitting and at rest and suddenly develop sharp, one-sided chest pain and then difficulty breathing. So this pain is known as pleuritic chest pain, which worsens with breathing or movement of the chest wall. So as an EMT, your responsibility is to recognize these signs and avoid interventions that might actually worsen the conditions, like a CPAP. Like a CPAP, which can exacerbate the pressure in that pleural space. Instead, your major intervention is going to be to provide supplemental oxygen, monitor the patient, and just prepare transport to a hospital where the air can actually be removed using a chest tube. Now, this slide, figure 16-10, this helps visualize what's actually happening during a pneumothorax. So as you look in this diagram, when the lung surface is breached, either due to a ruptured bleb or a tear in the diseased tissue, air leaks from the lung into that pleural cavity. Now, the pressure that builds up prevents the lung from expanding, and as air continues to enter this space, the lung continues to collapse. In a spontaneous pneumothorax, the amount of collapse can actually vary. A small one may cause like mild symptoms, while a large pneumothorax can lead to severe respiratory distress. In rare but like serious cases, the pressure continues to build and actually pushes on the mediastinum and the other lung into the opposite side of the chest. And that's a condition that we're going to call tension pneumothorax. This is going to be obviously a life-threatening emergency. Now, clinically, you may hear absent or diminished breath sounds on one side, and the patient may show signs of hypoxia, anxiety, tachycardia. So it's essential to monitor these patients carefully and watch for signs of deterioration. Another late sign would be what we call a tracheal deviation, where that pressure inside that chest keeps pushing, and the whole trachea starts to shift over. Now, again, that's going to be more of a late sign. But in terms of treatment, it's important to not apply a CPAP or positive pressure ventilations unless the patient completely stops breathing and they actually require ventilation support. These patients really need rapid hospital care, but you and your professionalism, your calm demeanor, and your focused assessment can make a large difference while on scene. Now, a pleural effusion is a collection of the fluid in the pleural space. Okay, so outside the lungs, but inside the chest cavity. The fluid really compresses the lung, and it's going to limit the ability for it to expand, and that's going to lead to a patient having shortness of breath. Now, unlike a pneumothorax where air enters the pleural space, a pleural effusion involves a liquid. Okay, this could be serious fluid, pus, or even blood, and it's all depending really on the cause. Now, a common underlying condition this is going to for pleural effusion includes congestive heart failure, infection, cancers, or some type of inflammatory disease like lupus. Now, pleural effusion doesn't typically occur like suddenly. Usually it's going to be a gradual kind of worsening of shortness of breath, difficulty breathing, sometimes with associated chest discomfort or cough. Breath sounds for these patients might be diminished or absent over the area where the fluid is collecting. And patients often report that symptoms improve when they are sitting upright in a high Fowler's position. Now, as EMTs, our role is to provide oxygen, okay? Position the patient for comfort, and again, that's going to be typically in the high Fowlers, and just transport rapidly, okay? There's no real pre-hospital treatment to remove that fluid, so this is something that's going to be, at least for at the EMT side of things, but so that's going to need to be done with ALS or with the hospital. They might do a certain procedure called a thoracentesis. But really recognizing the sign of a pleural effusion and not mistaking it for a kind of primary lung problem, that's the key to ensuring that proper care and transport decisions are made. Now, one of the more critical and time-sensitive emergencies you're going to encounter is going to be an airway obstruction. So when a patient presents with shortness of breath, difficulty breathing, you must always consider the possibility of a mechanical blockage of the airway. In our unconscious patients, this might be due to the patient's tongue falling backwards and blocking the oropharynx, or the aspiration of vomit. For our conscious patient, the obstruction is often due to a foreign body, like food, for example. And this is going to be particularly relevant in patients who were eating or drinking just prior to the symptoms onset. Now, the signs are often dramatic. The patient may clutch their throat, may be unable to speak or cough, and exhibit panic, stridor, or just complete silence. Now, with a partial obstruction, patients may be able to speak in short phrases or produce kind of like a noisy airflow, but these cases can worsen rapidly. Now, in field care, it's really important to identify and clear that obstruction as rapidly as possible. For partial obstructions, all you have to do is encourage the patient to cough and just monitor the situation. Now, for complete obstructions, responsive patients, you're going to do what's called abdominal thrusts, okay? And that's going to be for our adult and pediatrics. or do the appropriate, back blows and chest thrust techniques for our infant patients. If the patient becomes unconscious, begin with basic life support procedures and attempt to remove the obstruction using manual techniques or suctioning if the item is visible. Now, prompt action really saves lives in these situations. Airway obstruction is an immediate life threat, and you may be the only thing really standing between your patient and just full-on respiratory arrest. So this slide provides really a visual summary of two common causes of upper airway obstruction. So in image A, we see a foreign body. Okay, this could be food, right? And this can be lodged in the airway, and that creates a mechanical blockage that's preventing airflow. Now, this is really the classic choking emergency, and your response, again, has to be immediate and aggressive. If the patient can't speak, cough, or breathe, you need to perform abdominal thrusts or proceed with just basic life support measures, really depending on their level of consciousness. In image B, the obstruction isn't from an object, but from poor positioning of the head, and that causes the tongue to fall back into the throat. This is really common in our unconscious or semi-conscious patients, such as those who have been overdosed or suffered trauma. In this situation, your airway opening maneuvers become life-saving, really. So for patients without trauma, use the head tilt chin lift technique. For patients with suspected spinal injury, you're going to use the jaw thrust maneuver. If you suspect food or another object is the cause and the patient was eating prior to the onset of this difficulty breathing, you really want to prioritize rapid identification and clearing of that airway. And again, always remember, airway assessment should come first, and effective airway management is the most important skill you will use as an EMT. Because without an open airway, all the other interventions essentially become meaningless. Now, a pulmonary embolism, moving on, or you're commonly called just a PE, this is a life-threatening condition caused by a blood clot that actually travels to the lung, okay? And that's where it's going to block the blood flow into the pulmonary arteries. Now, while air may still enter the alveoli, no gas exchange occurs in the affected area because the blood flow is obstructed. Now, this results in a type of ventilation perfusion mismatch that rapidly leads to hypoxia. Now, the clot usually forms in the deep veins of the legs or the pelvis, and that's going to be a condition called deep vein thrombosis, or a DVT, and then breaks off and travels to the lungs, okay? Now, risk factors for a PE includes, long periods of immobility, recent surgery, pregnancies, cancers, and certain blood clotting disorders. Now, a PE can also originate in patients with AFib or atrial fibrillation, and that's where the clots actually form inside the heart. Now, the size of the embolus really determines on the severity of symptoms. A small PE might cause mild shortness of breath, while a large one can actually result in sudden death. So as EMTs, you won't be able to confirm a PE in the field, but your assessment and early suspicion can be life-saving. So if you suspect it based on sudden onset of shortness of breath, risk factors, clear lung sounds, initiate oxygen therapy, keep the patient calm and in a position of comfort, and then again, just prepare for rapid transport. Now, again, recognizing the signs and symptoms of a pulmonary embolism is of the utmost importance, okay? Because really these patients can deteriorate rapidly. Key symptoms include, again, sudden onset of shortness of breath, tachypnea, so that's just rapid breathing, tachycardia. The patient may complain of sharp pleuritic chest pain, and that's going to be pain that kind of worsens with deep breathing or coughing. They might appear anxious or restless, and in more severe cases, they're going to present with cyanosis, especially around the lips or the fingernails. You may also observe hypoxia even when the lung sounds are clear, and that's really the clinical red flag there. Another potential symptom is hemoptysis, which is just coughing up blood. This really occurs if the lung tissue starts to infarct, so the lung tissue starts to die due to the lack of circulation. Now, a PE really is one of the few medical emergencies that can mimic the sudden collapse of a trauma patient. So if you encounter a patient with a sudden unexplained respiratory complaint, especially if they're like post-surgical, they've been immobile for a while, like on a long train ride, plane ride, things of that nature, or just have a history of blood clots, you really need to have PE at the front of your mind as a differential diagnosis. Now, your treatment should include, high flow oxygen, clearing the airway if there's any blood, and then again, rapid transport. You should notify the receiving facility so they can prepare to perform any type of diagnostic imaging or initiate some type of anticoagulation or other critical interventions as soon as the patient arrives. Hyperventilation. So hyperventilation is a condition where the patient breathes faster and deeper than necessary. So it's really to the point where carbon dioxide levels drop below normal levels. Now, this may this may look like a kind of a benign panic attack, so to speak, but hyperventilation can also be a symptom of a more serious medical condition like diabetic ketoacidosis, maybe an aspirin overdose, sepsis, or maybe even a brain injury. So in these cases, the body is trying to compensate for acidosis, and acidosis is an excess of acid in the blood or the body tissues. So by blowing off more CO2 through rapid breathing, it kind of gets to that equilibrium aspect of which the body wants to be in. So don't be too quick to just assume it's just like anxiety. So you still need to complete a full primary assessment to rule out any life threats, and if a metabolic cause is present, treating that underlying issue is going to be really the important fix, and not just trying to slow down the breathing. Now, that being said, panic-induced hyperventilations do occur, particularly in the young patients or just very anxious individuals. These patients may report, dizziness, a tingling in the fingers and the lips, maybe some chest tightness, or just have the feeling that they can't catch their breath. But even though their oxygen saturations, may be normal or even high. The key to field care is just to remain calm, reassuring, monitor vital signs, and provide oxygen if there's any doubt. What you don't want to do is have the patient breathe into a paper bag, okay? That's a practice that can actually worsen hypoxia if there's a hidden medical cause. Instead, just guide them really to slow down their breathing just naturally, and prepare for rapid transport while continuing on your assessment. Now here's this slide is going to focus more on the physiological consequences of hyperventilation, especially when it's caused by psychological factors rather than a serious metabolic disturbance. So when someone breathes too rapidly or too deep for too long, they blow off too much carbon dioxide, which is going to lead to, again, a condition called alkalosis, and that's a buildup of excess base in the body's fluid. And now alkalosis affects the way calcium and kind of other electrolytes interact with the nervous system, and this is what leads to some of the classic symptoms you'll see in a hyperventilating patient. So they may complain of anxiety, lightheadedness, again dizziness, numbness, and tingling in the feet and hands, or even around the mouth. Some even experience what's called carpopedal spasms, and that's like a painful involuntary contraction of the hands and feet. This is especially common in patients having that panic attack. And while it looks dramatic, it's not life-threatening if the oxygenation of the patient is adequate. But as an EMT, it's your job to be certain that no serious cause of hyperventilation is being missed. Okay, so you'll still need to do a complete thorough assessment, maintain a calm, reassuring demeanor throughout the entire call. And again, do not have the patient breathe into a bag. It used to be a common practice, but now it's strongly discouraged. You could offer low flow oxygen if needed, speak calmly, and coach the patient towards more slower, controlled breathing. Always transport for evaluation, especially if this is their first episode, or if any kind of red flag arises during your assessment. So environmental and industrial exposures, that can actually present some of the most dangerous and really unpredictable respiratory emergencies you'll face in the field. These calls often involve inhalation or toxic gases or chemicals such as chlorine, ammonia, pesticides, cleaning solutions, and that can cause a direct injury to the airway and lungs. One particularly dangerous substance is carbon dioxide. Okay, this is a odorless, colorless, and tasteless gas, and often referred to as the silent killer. It's produced by fuel-burning appliances and fire, smoke, and patients exposed may not even realize they're being poisoned. Early symptoms of carbon monoxide poisoning include, headache, dizziness, fatigue, and eventual confusion, chest pain, loss of consciousness. What makes these calls especially risky is that EMTs can also become victims if the environment is not properly secured. Another telltale sign of carbon monoxide poisoning could be a red complexion, so to speak, a flushed red complexion. So your first priority really needs to be scene safety. So never enter a potential toxic area without proper PPE or clearance from trained hazmat personnel. Once the patient is removed from the exposure, treatment is going to include high flow oxygen via a non-rebreather mask, which is going to help displace that carbon monoxide from the hemoglobin. And now, if the patient is unconscious or has altered mental status, that's where you're going to have to be prepared to assist with ventilations and suction as needed. But really, rapid transport is the one of the crucial things you need to do. And in the more severe cases, patients actually might require a hyperbaric oxygen therapy. And then it's also important to remember to decontaminate your equipment and yourself after these calls and ensure the receiving facility is aware of the potential exposure risk. So your assessment of a respiratory emergency really begins before you even reach that patient, during your scene size. So first and foremost, prioritize scene safety. These respiratory emergencies can be caused by, infectious diseases, toxic substances like we just talked about, or, hazardous materials. So you always want to be on the lookout for any signs of danger. Use standard precautions, including your gloves, eye protection, and in cases of suspected, airborne illnesses, an N95 respirator. Next, determine the mechanism of injury or nature of illness. If it's really unclear why 911 was called, either to the patient, family members, or bystanders, that's what you got to figure out. Now, often a respiratory emergency will appear kind of obvious, but sometimes, those subtle symptoms like weakness, altered level of consciousness, are due to hypoxia or hypercapnia. So be alert for multiple patients with similar symptoms, and that could be an indication of a toxic exposure, maybe an infectious outbreak. So as you gather this information, you really want to start forming a working differential diagnosis that's just based on the environment, based on the patient's history, and just the visible clues. And remember, a thorough scene size-up is going to set the stage for a focused and effective primary assessment. It also protects you and your crew from any type of preventable exposure risk. Now, with the scene actually secured, your focus now shifts to the primary assessment, And this is going to be a rapid check to identify and treat any life-threatening conditions. So really begin by forming that general impression of the patient. What's the age? What position are they in? Are they, tracking me with their eyes? Does the patient appear to be in severe respiratory distress by, tripoding, gasping? Are they unable to speak? You want to quickly assess their mental status using that APPU scale. Are they alert and awake? Are they responding to verbal stimuli, painful stimuli, unresponsive? If the patient is alert or verbal, the brain is likely receiving adequate oxygen, at least for this time. Next, ask the question, about their chief complaint. This will usually be shortness of breath, chest tightness, or just a sense of being air hunger, or being air hungry. But be aware that in pediatric and our elderly patients, the signs kind of are less obvious. In children specifically, you want to look for retractions, the nasal flaring, irritability. In our elderly patients, you're looking more for that lethargy, confusion, or just any type of changes in their speech. This initial impression really helps guide the rest of your assessment and prioritize your interventions. So if you see clear signs of respiratory failure, such as altered mental status, cyanosis, breathing very shallow, that's where you need to initiate aggressive treatment, even before completing your full history or exam. So now that you've formed your general impression and identified any immediate life threats, now it's time to focus specifically on the airway and the breathing. Okay. First, check to ensure that the airway is patent, right? That it's open and unobstructed. Look for signs like gurgling, snoring, stridor, or just silence, each of which can point to either a partial or an overall complete airway obstruction. Now, if the airway is compromised, you want to use the appropriate technique to open it based on whether or not trauma is suspected. Once the airway is confirmed to be open, you're going to assess breathing. Is the patient breathing adequately? You're going to evaluate the rate, rhythm, the quality of the respirations. And remember, a normal respiratory rate for an adult is 12 to 20 per minute. Are their respirations labored? Are they shallow, irregular? Is the chest rising and falling symmetrically? Are there any accessory muscle use? These are all key indicators of how well the patient is ventilating. Okay, you just really got to ask yourself these three basic questions. Is air going in and out? Does the chest rise and fall with each breath? And is the rate appropriate for the patient's age and their condition? If the answer is no, then that's your cue that you need to intervene aggressively with oxygen, ventilatory support, and just advanced airway management, really just depending on the severity of the patient. Next time to listen to the breath sounds using your stethoscope. Now, this is a skill that takes practice, but again, it's going to provide very important information about what's happening inside the lungs. You want to place the stethoscope bilaterally on both sides, the right and left of the chest, and you want to compare breath sounds side to side. What you want to hear is just clear and equal breath sounds. Abnormal breath sounds are known as what we call adventitious sounds, and they include wheezing, rales, rhonchi, stridor. So let's kind of briefly go over all those, and then we're going to talk more about the exact placement of where to check it in lab. And you're going to find that depending on what textbook you look in, what skill sheet you're looking at, there's different ways to do rapid auscultation, different ways to do a full anterior posterior lung check. And there's a certain way I want you to do it in class, but again, whatever your instructor wants, that is fine. Well, let's kind of talk about the different adventitious sounds that we kind of have. And that's going to be, we have, rales, wheezing, stridor, rhonchi. There's so many different ones, but let's kind of talk about each one. So we have wheezing. Okay? So wheezing is a high-pitched, kind of like musical sound. It's more of a whistle heard mostly on expiration, so when they breathe out. And that's more associated with your asthma, COPD patients that have a bronchospasm. Okay, you have rales or crackles, and that's kind of like fine, kind of burgling, crackling sound heard on inspiration, and that's often a sign of like pulmonary edema or pneumonia. We have rhonchi, which is a kind of a lower pitched rattling sound, and that's caused by mucus in the larger airways. Pretty much in a chronic bronchitis. Stridor is like a high-pitched inspiratory sound that indicates some type of upper airway obstruction, usually from like a swelling or a foreign body. Typically, you'll see a lot in our tongues that kind of flop to the back of the throat. But again, in figure -1615, this illustrates the proper placement. And again, for the sounds, we're gonna play some videos and whatnot on Canvas for you, just to kind of help you can actually put sounds to these words. But in terms of the illustration of the proper placement of the stethoscope bell or diaphragm for auscultation, so you always want to auscultate directly on the skin, not over clothing, if at all possible. Okay, and listen through a full inspiratory and expiratory cycle. So inhale, exhale. If you hear deceased or absent breath sounds on one side, think of serious conditions like a pneumothorax, maybe a pleural effusion. Your ability to detect and just interpret lung sounds can really guide your interventions and potentially save lives. Okay, so again, we're going to talk about this more in lab in terms of the proper way procedurally to do this. But again, this is what your textbook is showing. So let's kind of move on to the circulation component of your assessment. We're, again, deep in the primary assessment. You want to start by, again, assessing the patient's pulses, okay? You want to assess for rate, rhythm, and quality. Again, if you're doing a rapid pulse check, you're just going to check for a max of 10 seconds, and you're just trying to see, hey, is it fast, slow, normal? What's the rhythm? What's the quality? Boom, if you're doing a full check, you're going to get a full how many times this heart's beating per minute. Now, do you want to know, is the pulse, is it strong? Is it regular? Is it weak and thready, or is it bounding? A fast or irregular pulse may indicate, some type of compensatory mechanism in response to the hypoxia, the shock or pain. You want to evaluate the patient for signs of shock. You're looking for hypoperfusion. This means just the tissues are not receiving adequate oxygen. So you're going to look at the skin, the color, the temperature, the moisture. And just the overall condition, pale, cool, and clammy skin, that can be an early indicator of the circulatory compromise. In children, we're going to do cap refill. It can be a very helpful tool, typically in our 6 and under kind of grouping. But you're going to put pressure on the nail bed, and that's going to push the blood out of the capillaries of that nail bed. And you're seeing how fast does that blood flow return. Typically, you want to see it in less than 2 seconds. You want to check for any type of major bleeding at this point, particularly in trauma cases, though, again, respiratory emergencies are rarely accompanied by a significant hemorrhage. Also take note of any peripheral cyanosis, especially in the lips or the nail beds, which can really indicate a prolonged hypoxia. Ultimately, though, this circulation check gives you a snapshot of how well that heart and how well that vascular system are responding to the patient's respiratory distress. And it really helps guide the urgency of your treatment and the aggressiveness that you should be and your transport decisions. Now, finally, based on all your findings so far, you're going to need to make a transport decision. Okay. Now, this is the final step in your primary assessment. You're just trying to formulate a plan, and this is very important. So, what treatment you should do, but also where should that patient go? If the patient is unstable, for example, altered level of consciousness, signs of respiratory failure, maybe evidence of poor perfusion, you should initiate rapid transport. Okay, that doesn't mean abandoning care. It just means beginning interventions en route while alerting the receiving facility. Now, start treatments like oxygen administration, assist ventilations if necessary, and just continue to reassess while you're en route. On the other hand, if the patient is stable, you may have time to complete a more thorough on-scene assessment, obtain your vital signs, and prepare the patient for transport in a more controlled manner. But again, remember, respiratory conditions can change rapidly. So even a patient who initially appears stable can deteriorate with little warning. So always err on the side of caution. In respiratory emergencies, your time is going to be of the utmost importance. Early recognition, early intervention, and just rapid transport is really what's going to save lives in the field. So you don't have to have all the answers, but you do need to make the right moves based on what you see, what you hear during the initial phases of care. Now, after completing your primary assessment and managing any immediate threats, it's really time to move on to your history taking, which really provides context to the respiratory emergency. You really want to start by asking about their chief complaint, which will often be, shortness of breath, but you want to get the patient to describe it in their own words. Then find out what the patient has already done to address their symptoms. Do they use a home nebulizer or an inhaler, or did they have an oxygen cylinder? Was there any changes in symptoms after those treatments? This information really helps you understand how the condition is progressing. You want to utilize the sample history format to gather a real full picture. Again, S is signs and symptoms. What are they feeling? What can you observe? Allergies, do they have any allergies? Respiratory patients, often have various triggers. Are they currently taking any medications? Are they prescribed a bronchodilator, a steroid, a diuretic? Do they have pertinent past medical history? Do they have COPD, asthma, CHF, pneumonia? Or have they had it before? When was their last oral intake? Useful for really patients who may require medications or have nausea. Events leading up to the illness. Did they recently have a cold, infection, exertion? This information sets the foundation really for determining whether the issue is a chronic, acute, infectious, or environmental condition. Now, while you may not get the answers to every question, especially in patients with the altered level of consciousness, gather as much information as possible and just supplement what the patient can't provide with input from family members, caregivers, or even bystanders. Now, once you have gathered general history, you'll want to focus on specifically on the respiratory symptoms. You can use the OPQRST mnemonic or the PACE mnemonic. So for OPQRST, typically used for pain assessment, but again, we can adapt it to shortness of breath. For onset, when did the breathing problem start? Was it sudden? Was it gradual? Provocation, palliation, what makes it better? What makes it worse? Does movement, lying down, or the use of an inhaler help? The quality, how the patient describes the breathing problem. Is it a tight, sharpness, suffocating? Region and radiation, right? So is the discomfort localized in the chest? Does it radiate anywhere? Severity on a scale of 0 to 10, 0 being you can breathe perfectly fine, 10 being you can't breathe at all. How would you rate it? And then time, has the condition changed over or worsened over time? And then get a specific time when it started. Then we have the PACE mnemonic. So this can be more focused for a respiratory assessment, and it's going to be helpful for your shortness of breath cases. You have your P, which is progression. Has it been getting worse over time? A, associated chest pain. Is chest pain present along with breathing difficulty? S, sputum. Is the patient coughing up mucus? If they are, what color is it? T, talking tiredness. Can the patient speak in full sentences, or do they get tired relatively quickly? E, exercise tolerance, right? Can the patient walk a few steps, or when they or do they get winded by minimal activity? These questions really offer critical clues and help differentiate between cardiac, pulmonary, or just anxiety-related causes of this respiratory distress. They can also help guide your decisions regarding your interventions, your urgency, the treatment, and just the transport priorities. Now, once the primary assessment and history taking are complete and all your immediate interventions are kind of in place, it's really time to move into your secondary assessment, which really allows you to gather more detailed physical findings. For your respiratory emergencies, this often is going to include a focused exam of the chest, the lungs. You want to look for visual signs like accessory muscle use, retraction, cyanosis, barrel, chest, tripod positioning. For patients with known chronic conditions like COPD, you want to check for signs that support your clinical impression. That includes, patients over the age of 50, they have a history of smoking, ongoing fatigue and difficulty breathing, abnormal breath sounds like bronchi, wheezing, maybe diminished sounds. Also, inspect for clubbing of the fingers, and that can suggest long-standing hypoxia. You want to palpate for symmetry during chest rise and fall, observe for signs of chest trauma, swelling, deformity, and then continue to auscultate lung sounds from the top to bottom and side to side. You want to use all your findings to really track the progression of the illness and determine how well the patient is responding to your interventions. Now, these observations will also be really helpful for the receiving facility when making a clinical diagnosis or deciding on further treatments. The second part of your secondary includes just ongoing monitoring and prepares for any potential deterioration. Some respiratory patients may initially appear stable, but they really can deteriorate quite rapidly, especially those with underlying heart or lung disease. So recheck your vital signs fairly regularly with a focus on the respiratory rate and effort, your pulse ox, heart rate and the rhythm, mental status. In patients with asthma and COPD, assess the effectiveness of medications like your metered-dose inhalers, nebulizers, or look for signs of overuse, like tachycardia, nervousness, maybe tremors. For patients receiving oxygen, you want to monitor for changes in their saturations, mental status, which may indicate hypoxia or hypercapnia. If you have access to capnography, use it to monitor end-tidal CO2, especially in ventilated or high-risk patients. Also be alert for signs of fatigue. If the patient starts to slow their breathing, becomes more lethargic or stop speaking, they may be heading towards respiratory failure. Your secondary assessment also includes preparing for reassessment. Are the interventions working? Is the patient improving? Are they stabilizing or are they worsening? This constant observation and adjustment are what transform basic EMT care into really proactive life-saving management. Now, once you performed your primary and secondary assessment and you began treatment, it's time to enter that reassessment phase. And it's not a passive, it should be really an active, continuous process that ensures your interventions are working and that your patient isn't deteriorating. So start by repeating your primary assessment. Is the patient's airway still open? Is their breathing rate and quality improving? Has the circulation changed? Are they showing signs of shock or hypoperfusion? You also want to monitor vital signs frequently, at least 5 minutes for unstable, 15 minutes for stable. Look for improvement in their mental status, their respiratory effort, oxygen sats. If you've administered oxygen, use the BVM or assist with medication. Ask yourself, is there a clinical response? Are lung sounds improving? Is breathing become less labored? If not, you may need to escalate care, and this could mean initiating positive pressure ventilations, repositioning the patient, or just preparing for rapid transport if they begin to fatigue or lose consciousness. Your reassessment is really how we measure the success of our care in the field, and it's going to determine whether to continue, adjust, or just abandon a certain approach. So always document your findings and remain alert for any subtle changes. They often come before a major decompensation. Now, in most respiratory emergencies, your primary treatment will be the administration of supplemental oxygen. Start with a non-rebreather mask at 15 liters per minute. Unless the patient is unable to tolerate it, in that case, you're probably going to use a nasal cannula and just titrate it upward as needed. For patients in severe respiratory distress who, is alert, breathing rapidly, that's where your CPAP, your continuous positive airway pressure, may be more indicated, and that depends on your local protocol. The CPAP can be extremely effective in conditions like pulmonary edema, COPD, because it keeps the alveoli open and it's going to improve gas exchange. But if it is contraindicating patients with low blood pressure, altered mental status, suspected pneumothorax. Some patients will have their own medication on hand, like a metered-dose inhaler, maybe some type of small volume nebulizer. So these typically contain beta agonists like albuterol, which is going to relax the smooth muscle of the bronchioles and open up the airway. Now, depending on your scope of practice and your local guidelines, again, you're going to be able to assist the patient in using these medications. If you can, ensure that the medication is prescribed, it's not expired, you want to dice it, do your 9-patient rights, and make sure the patient's alert enough for it to be used, okay? Now, these tools, when combined with a focused assessment and calm presence, can be a powerful intervention in reversing the early signs of respiratory failure. So before assisting, again, with any inhaled medication like your metered-dose inhaler, it's important to review the patient rights. So it's the right patient, right medication, right dose, right drug, right route, right time, right documentation, right to refusal, right to education, and then just right outcomes. Now, and then, of course, you want to dice your medication, make sure it's the right drug. Depending on the type of medication, you're looking at the integrity, the clarity, the concentration, and, of course, the expiration date. Another important aspect, has the patient already taken the medication? Because certain medications, you only have a certain max dose you can provide based on your standing orders. But that can always change based on your contacting base to see if medical control can give you more authority. Now, most of these medications work by relaxing the muscles around that bronchial tree, and that dilates the airways, and that's going to improve airflow. So, again, common medication that you're going to see is going to be albuterol, ipratropium, levoalbuterol. But again, it's important to be aware of the side effects because after you administer, okay, so it's not unusual to see, a slight increase in pulse rate, nervousness, tremors. They are expected responses and usually not dangerous, but it's really important to monitor the patient closely, especially if multiple doses are given. If the patient begins to deteriorate, develop fatigue, cyanosis, altered level of consciousness, you may need to escalate care to those positive pressure ventilations. But again, always document what medication was given, when, and what was the patient's response. It's very important to understand that these medications do not replace proper airway management and oxygen therapy. They're just a part of the broader layered approach to stabilizing a patient's respiratory distress. So when in doubt, always call medical control and just, again, follow your local protocols. Now, in cases of upper respiratory and lower respiratory infections like croup, epiglottitis, pneumonia, your treatment approach must be kind of tailored specifically. So, for many of these conditions, the best initial treatment is humidified oxygen if it's available. The humidification really soothes the irritated airways and can help loosen those secretions, making breathing easier. But again, certain infections, especially like epiglottitis, that requires extreme caution. You never want to insert an OPA or perform deep suctioning or manipulate the airway, especially in a child who is drooling or sitting in a tripod position, okay? Because doing so can trigger a laryngeospasm and cause a complete obstruction. So the same caution really applies in patients who are anxious, already struggling to breathe. Your priorities are always going to be to minimize the agitation, provide calm reassurance, and deliver that high flow oxygen. You want to position the patient comfortably, usually in an upright position, and just prepare for prompt transport. In these cases, the definitive treatment often requires an advanced airway management, antibiotics, and hospitalization. But again, your role is going to be to stabilize and support the patient while they meet or go for a definitive care. So always alert the receiving facility when a patient may have any type of contagious infection, and disinfect all your equipment after every single call. Now, when you're managing a patient with acute pulmonary edema, okay, your goal is really maximize oxygenation and minimize further fluid accumulation in the lungs. Okay, most cases are the result of congestive heart failure, where the left side of the heart really can't keep up with the blood returning from the lungs. The result is a fluid backing up into the alveoli, really creating a barrier for gas exchange. So these patients often feel like they're suffocating and may be extremely anxious or even combative. They might produce that pink frothy sputum, have crackles or rails upon auscultations. So your treatment really begins with administering 100% oxygen, preferably by non-rebreather mask if the patient is conscious, if they're breathing rapidly and have good blood pressure. You may actually be able to use a CPAP, which really delivers continuous positive airway pressure to push the fluid back into the capillaries and reopen the alveoli. Now, the CPAP has been shown to reduce the need for intubation and improve outcomes in many of the CHF-related type emergencies. But again, be cautious though. CPAP is contraindicated for patients who are hypotensive or who are altered. Okay. Always suction as needed, maintain clear airway, position the patient in an upright position, and that, again, that's going to help ease the work of breathing for the patient. Then finally, of course, transport promptly, reassess frequently, probably again 5 to 15 minutes, depending on the patient's status. And again, these patients can always deteriorate fairly quickly if their cardiac function continues to decline. When you're managing a patient with COPD, though, it's important to remember that if that they kind of live life in a compromised respiratory function every day. So when they call 911, it's usually because they've entered an exacerbation period, and that just means that their usual symptoms, like cough and shortness of breath, have worsened beyond what they can actually manage. So you still want to, for those patients, start by providing oxygen, but again, be mindful of your flow rate. Because although most COPD patients tolerate high flow oxygen pretty well, some retain carbon dioxide, and aggressive oxygenation could suppress their whole respiratory drive. So it is best practices would begin with low flow oxygen via nasal cannula, then titrated upwards based on the SpO2 readings and the overall patient's presentation. Now, if they have a prescribed inhaler or nebulizer and are alert enough to use it, you may assist them in administering just according to your local protocol. Really watch for signs of medication overuse, which can be, again, the tachycardia, nervousness, and the tremors. Most of your COPD patients will benefit from being in the upright position, which is going to help maximize their lung expansion. But again, COPD exacerbations often stem from like a secondary infection. So even if they seem stable now, rapid transport is critical so they can receive further treatment. including bronchodilators, steroids, antibiotics. Again, always reassess frequently and be prepared to assist ventilations if the patient begins to fatigue as they're breathing. Asthma. So asthma is one of the more common respiratory emergencies you're going to see in the field. In many cases, it can be effectively managed with just early aggressive treatment. During an asthma attack, again, the bronchial spasm, the airways narrow, and then the mucus production is going to increase, making it very difficult to exhale. The patient may have audible wheezing, labored breathing, and may just speak in short, broken sentences. You really want to begin with oxygen administration. Prepare to assist the patient with their prescribed inhaler. Common, again, medications are going to be albuterol. Your job here is to verify the medication, make sure it's not expired, assist according to your protocol. Be prepared to suction if the mucus production is excessive, particularly in those severe attacks. Now, if symptoms persist or worsen despite the bronchodilator therapy, just be ready to escalate care. A patient who becomes tired, confused, or quiet with reduced wheezing may be approaching respiratory failure. Now, in these cases, you really want to initiate assisted positive pressure ventilations, rapid transport, notify the receiving facility. Your asthma patients can deteriorate rapidly, but again, with appropriate field management, you can often relieve those symptoms and just stabilize the patient while en route to the hospital. Hay fever, treatment of hay fever, which is allergic rhinitis. Again, rarely an emergency. It typically causes cold-like symptoms, sneezing, runny nose, congestion. But you may encounter it incidentally, but if you usually doesn't require EMS transport. That being said, individuals with hay fever, again, they're more prone to severe allergic reactions like anaphylaxis, and that is where the life-threatening aspect comes into play. Anaphylaxis, again, results in airway swelling, bronchoconstriction, vasodilation, shock. They're going to have urticaria, angioedema, wheezing, stridor, swelling of the tongue, hypotension, sometimes nausea and vomiting. So if the patient has been exposed to a known allergen and is showing signs of respiratory distress, circulatory collapse, that's where epinephrine must be administered immediately. If they do carry an EpiPen, you can assist them in using it. If not, your protocol allows it, you can administer it yourself using your services supply. But it really just depends on the department you work for. Now, follow up with oxygen positioning the patient in a way that supports breathing, and then again, just rapid transport. So even if the symptoms improve after epi, there's a risk of what we call rebound anaphylaxis. So the hospital evaluation is imperative. Avoid delaying care for other assessments. When it comes to anaphylaxis, it's all about early recognition and epinephrine. Okay. Now, spontaneous pneumo. So these patients often experience shortness of breath very rapidly, pleuritic chest pain, even without signs of trauma. Classic signs to look for: absent or diminished signs on the affected side. Your immediate treatment is just going to be provide supplemental oxygen and transport patient to the hospital. You want to avoid the CPAP, avoid doing positive pressure ventilations unless absolutely necessary, because again, that could make it worse, okay, by forcing air into the pleural space. Now, monitor the patient closely for signs of attention pneumothorax, which includes that hypotension, distended neck veins, which we call jugular vein distension, and tracheal deviation, which again is a later sign. Now, with pleural effusion, the tissue is not air but fluid accumulation around the lungs. This can occur gradually from CHF, cancer, infection, and it just restricts the lung's ability to expand. The patient will often feel better when sitting upright. Treatment in the field focuses really on oxygen support, patient positioning, and just rapid transport. Removal of the fluid must be performed at the hospital through a thoracentesis. Okay, so but both of these conditions really impair ventilation from the outside, not within the alveoli, which makes auscultation and careful patient positioning essential parts of the management strategy. Airway obstruction, again, one of the most immediate threats to life in EMS. If the obstruction is partial, the patient may still be able to speak or cough. All you have to do is encourage them to cough. Even if effective, and closely monitor any deterioration. If the obstruction becomes complete, or if they can't speak, cough, or breathe, that's where you're going to act. You're going to do your abdominal thrust in the response of adults and pediatrics, and then the back blows and chest thrust in our infant patients. If the patient goes unresponsive, that's when you're going to begin CPR, but the only difference is check the airway before you provide those ventilations when you're doing your ratios. If unresponsive patients, or in unresponsive patients with an airway obstruction, it can be caused by the tongue, vomitus, foreign objects. So make sure you use proper positioning, suctioning if needed, and just basic airway adjuncts like your OPA or MPA. After clearing the airway, provide oxygen, monitor the patient for rebound swelling, and just transport rapidly. In all cases, really be cautious. Airway interventions, if swelling or foreign material is still present, always prepare for deterioration and never assume the problem is resolved just because the patient starts to breathe again. Obstructions can recur or lead to complications like aspiration pneumonia. Moving on, pulmonary embolism, or the PE. That's more of a circulatory emergency that causes respiratory collapse. Okay, so remember the airways may be clear, the lung sounds normal, but the blood is not reaching the alveoli, and that's due to the clot that's being lodged in the pulmonary arteries. So this mismatch prevents oxygen from entering the bloodstream, even though ventilation may appear intact. So start treatment with high flow O2, even if the patient's oxygen saturations appear to be normal, because again, they may still be hypoxic at the tissue level. Keep the patient in a position of comfort, usually sitting up. If the patient has hemoptysis, just coughing up blood, be ready to clear the airway with suctioning to maintain airway patency. Now, patients with a PE often present with chest pain, tachypnea, anxiety. They may be pale, sweaty, fearful, obviously. So don't delay transport. Notify the receiving facility of any suspected PE so that they can prepare rapid imaging and treatment with thrombolytics, anticoagulants. In your more severe cases, a PE can lead to cardiac arrest. So again, continually reassess for changes in their condition and prepare for resuscitation if it's indicated. Your field care really sets the foundation for just time-sensitive in-hospital interventions. Now, although hyperventilation, again, can be associated with anxiety, panic attacks, you always approach it as a potentially serious problem until you're proven otherwise. So begin with a full primary assessment, including the mental status check, respiratory effort, and oxygen sats. Rule out possible causes like a metabolic acidosis, toxic ingestion, or head trauma. If you determine the hyperventilation is due to anxiety or maybe just some type of emotional distress, your focus is going to shift to just calming and reassuring the patient. Avoid just telling them breathe slower. This actually could increase anxiety. Instead, you got to use calm coaching to help guide their breathing. Again, do not use the outdated technique of having them breathe into a paper bag, as this can, again, dangerously reduce O2 levels if the hyperventilation is being driven by a medical issue. Okay. Provide supplemental oxygen if there's any doubt about the cause or if their saturation level is borderline. Monitor closely for any changes in their level of consciousness, respiratory effort, and just, again, prepare for transport. If the patient begins experiencing tingling, carpopedal spasms, or dizziness, explain that they're just temporary effects of breathing too fast and usually resolve once they start to slow down. Your overall tone and presence are often just as therapeutic as your interventions during these calls. Now, when responding to calls involving like the environmental or industrial exposures, your first responsibility, again, is always ensure safety. So do not enter any hazardous environment unless it's been cleared, again, by hazmat. These inhalation injuries from substances like ammonia, chlorine gas, pesticides, cleaning chemicals, that can significantly cause airway irritation, bronchospasm, pulmonary edema, or even systemic toxicity. So once the patient has been removed from that environment and decontaminated, that's when you're able to start your treatment. And you're going to assess the airway, the breathing, the circulation, your ABCs. You're going to administer high flow O2, and again, be prepared to suction if there are any secretions or blood in the airway. Now, if the patient's symptoms suggest a bronchospasm and your protocol does allow it, you could consider a bronchodilator therapy. In the case of carbon monoxide poisoning, oxygen is going to be the most important aspect here because, again, it's going to help displace the carbon dioxide molecules the carbon monoxide molecules from the hemoglobin. Even if the pulse oximeter appears normal, tissue hypoxia may still exist because the oximeters can't differentiate between oxygen and carbon dioxide or carbon monoxide saturations. Always notify the receiving hospital about the substance involved and ensure that the ambulance and the equipment are decontaminated after the call. These environmental and toxic inhalation emergencies can escalate so quickly, so it's really important to stay vigilant, protect yourself, and act rapidly to stabilize the airway and support breathing of the patient. Foreign body aspiration, this is particularly critical in our young children and older adults. In most often occurs in children during eating or play when small objects like peanuts or toys are accidentally inhaled. The object may fully or partially obstruct the airway, leading to confusion, sudden onset of coughing, choking, wheezing, or stridor. In our infants and toddlers, you may see drooling, cyanosis, or just a complete stoppage of breathing. If the child is conscious but obstructed, that's where you're going to use the back blows and the chest thrust for our infants, and then we'll use abdominal thrust for the children and adults. And again, we're going to align ourselves with the American Heart Association guidelines. Now, for patients with a tracheostomy tube, emergencies can arise when the tube becomes obstructed by mucus, becomes dislodged, or infected. These patients may have had surgery for airway cancer, trauma, or chronic pulmonary conditions. Now, if the tube is blocked, your priority is to suction it thoroughly using the appropriate sterile technique. If you are trained and authorized, you may also assist in replacing the trach tube with a spare. But in both aspiration and tracheostomy dysfunction, you're going to provide oxygen, monitor airway compromise, and then again prepare for rapid transport. These patients are really vulnerable and may deteriorate quickly, especially if their baseline condition is already compromised. Pediatric patients. So with pediatric patients with asthma, they often present similar to adults: wheezing, retractions, nasal flaring, difficulty speaking. However, children may refuse oxygen masks due to just fear or discomfort. In those cases, you have to provide oxygen via a blow-by method. That's where the mask is kind of held a few inches from the child's face to allow them to inhale enriched air without the mask actually touching their skin. Many pediatric patients, asthma patients, carry MDIs with spacers, which can actually assist which you can actually assist with under the local protocol. But always monitor for fatigue, as this signals that the child is nearing respiratory failure. Now, regarding cystic fibrosis, this is a genetic disorder that affects the lungs and digestive system. So it causes the production of thick, kind of like sticky mucus, which clogs the airway and leads to chronic infections. These patients are at high risk of respiratory compromise, especially during an illness. So you may be called for difficulty breathing, productive cough, fever, and you want to, and probably signs of dehydration. In the field, your care really includes suctioning to help clear the mucus from the airway, providing O2 support. Now, children and young adults with cystic fibrosis often know their condition very well, so listen to them or their caregiver. Be cautious with airway interventions, as like excessive suctioning or stimulation may worsen the distress. Transport these patients promptly, notify the hospital of their diagnosis, so respiratory therapy can actually be prepared. So we've now completed our Chapter 16 Respiratory Emergency lecture. So now, again, this is a topic that is foundational and life-saving in the EMS profession. So let's kind of reflect on what we covered. Respiratory complaints, again, are going to be one of the more common calls you'll receive. And they're one of the more urgent, from asthma to COPD to anaphylaxis, pneumonia, pulmonary edema, foreign body obstruction. Each condition is going to present you with unique challenges, but they all share the same theme, and that's airway and ventilation comes first. So throughout this chapter, you've learned how to recognize signs of respiratory distress, perform detailed assessments using tools like OPQRST, paced and lung auscultations, and implementation of immediate treatments like oxygen administration, inhaler assistance, and airway maneuvers. You've also seen the importance of a reassessment, calm scene control, and knowing how when to escalate care. Whether through a CPAP, bag valve mask, or rapid transport. So it's important to remember respiratory failure can occur rapidly and silently. So it's not always the loud, gasping patients who are crashing. It might be the one who suddenly becomes quiet, tired, or just confused. So trust your training, your reassessment skills, and your instincts. As you move forward in your EMT education into the field, just carry this knowledge with you. So breathing is something we all take for granted until it becomes a struggle. So your ability to respond with speed, respond with accuracy and compassion can really mean the difference between life and death for your patient. So again, thank you so much for your attention, for watching, and then I hope to see you next time.